So the truth, everyone know that we should start with TAVI, and would like to thank Michael, who made my life easy by talking about TROS. It's a great procedure, but usually what we do, we take the pulmonary valve, we put it in the aortic position, and we give them a graft that at best and at most 5 to 6 years need a complex intervention. So just before I go to my talk, he's a great speaker and a great surgeon, and I know that he is doing TAVI, and he focused in his talk about parameter that will not change mortality, and will show you the real data about left bundle, and all this is before fine-tuning of our how we do the TAVI with high implantation, cusp overlap, and commissure alignment. All the number mentioned in his slides is a bit old, and we'll show you a good data now. So if all the risks and benefits are weighted between SAVR and TAVR, then TAVR is much less invasive, recovery is shorter, and patient is back in society faster. In fact, next day, not 5 to 6 days. Treatment of aortic valve stenosis. I will show you something really, it will change your mind. So the TAVI trial evolution, we started from an inoperable patient, then very high risk patient, then high surgical patient, then intermediate, then low risk. But trust me, my colleague, he give, he spent time talking about bicuspid. We know that bicuspid surgery is better, but the pathology is different from one country to another. Bicuspid probably in North America, but here we have something called rheumatic aortic valve stenosis, and it's a pretty common. Can we move to young? If young patient with isolated AS who refuse to receive mechanical valves, if refused to accept mechanical valve, the choice of TAVR versus SAVR is an ongoing debate and concern. Are we following the guidelines? Look at this. Michael, he showed you I think the same slides here in 2020, the majority, more than 80, they go for TAVI. The patient less than 65, still the SAVR, like in 2015, SAVR is like 83%, but now we are 1-to-1 because people realize that giving a surgical bioprosthetic valve is not better than giving the proper type of TAVI or the proper device, TAVI device to the patient. Low surgical risk, consistency of trial result, same message. Low risk patient, do better with TAVR in case you use bioprosthetic valve. The Evolute 4-year TAVR showed durable outcomes for a primary endpoint of death or disabling stroke, 26% relative reduction in hazard for death or disabling stroke. Stroke is very important. Better hemodynamic, that's for sure. 84.7 of TAVR, no trace paravalvular leak, regurgitation compared with 98.4. So trace. No difference in moderate or greater paravalvular leak, which make a matter. So what? Mild paravalvular leak. I know mild valvular leak data is inconsistent. Some of the registry show that it play, increase morbidity and mortality in the future, but the good registry will show you that it show no difference. Significant reduction in composite primary endpoint in favor of TAVR with superiority over SAVR driven by rehospitalization. So if I have, any degree mild regurg, but it will not cause rehospitalization, then I will go for TAVR. Significant reduction in new onset atrial fibrillation, length of hospitalization, and death or stroke at 30 years. Rate of moderate or severe valvular leak were similar in both. Rate of mild valvular regurg higher in TAVR, and if it is translated into rehospitalization and mortality, I will not see any difference. Notion 10 years data show that during the follow-up there is no difference, but the hemodynamic is superior in case of the TAVI. Meta-analysis of low-risk trial, 4 randomized controlled trials. Notion, partner 3, evaluate low risk and short TAVI with STC less than 3%. Almost 2,900 patients, divide both in TAVR and SAVR. After 1 year, TAVR associated with, all in favor of TAVR. Is it clear? MACE, overall mortality, cardiovascular mortality, life-threatening, disabling bleeding, atrial fibrillation, acute kidney injury, stroke, major vascular complication, and permanent pacemaker implantation. TAVR is safe or safer than SAVR, less invasive, faster recovery. Issue. Let's take it one by one. Optimization for lifetime need, durability, coronary access, future intervention, explantation. In our area, in our region, the survival up to 76.24 year is here is the median. United Arab Emirates 78.9, Saudi Arabia 76. I'm just giving you example. Iran 74. How long do patients survive after SAVR? Durability matter in low risk 6 to 64. And if you look here, median survival time, in year based, and here is the age of the operation, you will find that all the death occurs at 85, and the risk group, the low, of course, will have better survival, intermediate better than the high risk. Mortality, valve deterioration, hemodynamic, and benign prostatic, the patient prostatic mismatch. It's an area of great interest, and we cannot deny it, that surgical patient, and we'll show you data that it is higher than TAVR. Here is the median age, is the how durable is SAVR. Median age is 8 to 9 years, 50% chance of being replaced at 80 to 9 years. 50%. That is SAVR. So this is the guy who is doing the hiking, that Michael, he just show he will be one of the 50%. SAVR is not durable. That's a false impression. The false impression that SAVR is durable. SAVR is not durable. Young patient degenerate SAVR earlier. This is the STC database. The younger the patient, the higher risk of valve deterioration. Durability is not better with SAVR in young. Durability in young is 8 to 10%, is very clear in these two graphs. SAVR is not durable. Long-term TAVI durability. Look at this. Look at this prestigious science. This is long-term TAVI durability from recent literature. Robustic 8, 7, and it's doing good, and it's ongoing. So we approach the 8-year and 8 year, and look at the number. Valve deterioration and failure did not exceed 5 to 6%. 8 study follow-up, 8-year severe valve deterioration is 2.5%. Valve failure between 0.6 to 7.5%. In surgical study, valve deterioration requiring an operation less than 15% at 10 years. So our number, if it is not better, is the same. Notion trial, 8 years. TAVI for TAVR, significant, the valve deterioration was significant lower in TAVR patient. Core valve, bull data, again, the valve deterioration is better, is less with TAVR compared to SAVR. Hemodynamic, I don't want to go through this because definitely TAVR is better than SAVR. Patient prosthesis mismatch, it's increased mortality and morbidity, and it is common in surgical valve. And if you want to avoid this, you're gonna do like an extra work during your surgical approach with annular enlargement and increase the risk of surgery. And I'm glad some of the surgeons they give the true number for the patient about this extra steps during the operation, like the number of the complication, and most likely the patient wisely will go for TAVR. The patient prosthesis mismatch after SAVR and TAVR, you can look here, the prevalence, TAVR tend to result in fewer cases of patient prosthesis mismatch compared to SAVR, especially with valve design in TAVR that optimize effective aortic area. And this is before it was only the supraannular. Now even the balloon expandable like the Mayval, it show in the landmark trial that the hemodynamic is superior, is good. Severe patient prosthesis mismatch associated with worse outcome, and we know that. So now, durability, we are the same if so far. Patient hemodynamic, we are better. I will go to this slide quickly. And the deterioration, the patient prosthetic mismatch, we are far less than the SAVR. So Michael, he gave a couple of examples, and I will give you one true example. 66-year-old male, diabetes, hypertension, severe aortic valve stenosis, with Magna E size 21, presented with dyspnea. So 5 years. So one of the important messages here, you have to apply the data carefully on the nature of your patient. Our area, more diabetes than anybody else, and more renal failure than anybody else. If you will not give young patient a mechanical valve, then for me, TAVI is the best, because such scenario, renal failure, a quick degeneration of the surgical valve. So why I need to open the chest of the patient, and sometimes I need to do annular enlargement, an extra complication, while I can do it with TAVI. So he came in with, as you can see, significant gradient, significant LPH, very symptomatic. So this is, and he is a smoker. So this is his CT. I will skip this. So we decide to go and do for him TAV insert. We will not send him for redo for another bioprosthetic valve. So what we did is, for the routine, we look at the coronary, it's normal. And then if you look at we reviewed the echo of the patient. Since the day of the surgery, he's having 2-digit mean pressure grade. We know that after 5 years, he will degenerate. So we gave him the supraannular device, and it was done successfully. And then you can see there is a good gradient. We don't want to do the same mistake that the surgeon he did. He gave him a small valve. So we took a true balloon sorry, it's written Atlas, but that's a true balloon, size 20, and we fracture the valve. And now the gradient is almost zero. When we did this procedure, there is a couple of slides here is missed. I usually do, like, I think, you know, the people seeing us doing cases of live transmission, I always routinely do coronary access for all type of TAVI device implant. Every single patient. After I do the TAVI, I do coronary engagement left and right in the standard view. So when he go back to his city or where he came from, the CD in his hand showing the intervention is there, which cells, which area we engage the coronary artery. So this patient, if he was sent early, we would give him a short frame TAVI device, and we avoid him open heart surgery. Another device here, the Wail. I always implant high, and this is a 21 in a device in obese patient. So as there is a revolution and there is progression in the surgical device, there is a progression and new technology in each valve. Decrease, choosing the leaflet, the size of the leaflet, the frame itself, bulky or no. So this is the Wail. It is doing very good, 2 good studies, and the hemodynamic, look at this, obese patient with large body surface area and is having 0 gradient, almost 0. And if you're going to give him a surgical valve, look at the sinus and look at the aorta, the sinuses and the sinotubular junction and the annulus. Is no way to give him a surgical valve without doing root enlargement and increase the complication during the procedure. And while you give him here a TAVI, and next day or same day home. And this is his hemodynamic. And I noticed in my colleague, Dr. Michael, his, talking about a lot of bicuspid. Usually we don't do TAVI in bicuspid. We know that from too many studies, even the one represented recently at the Euro BCR and London valve, that surgery is better, but we have a different pathology in our region. Young patient, they don't want surgery, and they have rheumatic aortic valve stenosis. Some of them, like this patient, have 0 calcium. What to do with such patient? Do you want to operate and give them a surgical valve? And you know that mitral, the mild or moderate, will be severe soon because of the rheumatic heart disease progression. This is a 62-year-old lady came with the shortness of breath. She don't want mechanical valve, and she's wise. She don't want surgical valve. So we give her the this supraannular device, Accurate U2. This is, for me, I think, the best device to have valve in the future. As you can see, down is a small frame, and up is just like to anchor the valve, a couple of wires, and it's easy coronary access. And this upper crown, it push down the leaflet and make it away from the left main. And I will show you a nice image here. This was done this week, Sunday, I think. You can see the leaflet here and the crown pushing the leaflet down. No paravalvular leak.
You have 1 more minute.
I'm almost done, sir. You didn't say so to
well, we are predominant surgeons here, so.
Okay, so very important, the message. No, let's just have a heart team meeting, and let's just be, frank with the patient. Let's give him as I show you here in this slide, short frame, such complex, anatomy, no root enlargement, and and let's say that the duration is the same. Regarding the left bundle and right bundle, left bundle branch and heart block, I think it is a history. Now we implant very high, and Gilbert Tang and his colleague, they did very good to teach us how to do it. And there's no consensus data about left bundle, what it's going to do in the future. And there's no consensus data what permanent pacemaker will do in the future. Saying so, the number went down. In our paper is 6.7% after adopting the cusp overlap and commissural alignment. With that, I'd like to thank you. Just I want the last two slides, please. Just 1 second. I would like to invite you all for the upcoming, if you allow me, the Saudi Arabian Cardiac Intervention Society meeting in February. It's a great meeting, a great gathering. And also in April, that's going to be in Riyadh. And also, next slide, please. Next slides. The TCT plus Middle East also will be in Riyadh. We'll be very happy to have you with us. Dr. Adel Tash is a major contributor in this meeting. And with that, I would like to thank you for the invitation.